Rahim. With a very interesting and common symptom in cardiology, palpitations. I wonder how many of you have experienced palpitations in the audience. Just remember, when you were going to present yourself for Viva examination, what was going on at that time? Palpitations. Again, remember when you are in a fit of rage, when you are excited, when you are having unexpected results or unexpected situations in life, all of us, we experience palpitations. So palpitations is something that all of us at one stage or another, maybe on a daily basis, we experience, all of us. So what is meant by palpitation? Next please. Palpitation basically is awareness of one's heartbeat. When you are aware of your own heartbeat, which is inconvenient and unexpected. When you are expecting it, you don't feel palpitations. Although you have the same kind of situation clinically, your heart is racing away, you're having tightness in the chest or something, you can feel inside your chest, but still you do not complain of palpitation because you're engrossed, you are busy in that particular situation in life. But when it is unexpected, when you are lying down, when you're watching television and something happens, when you are not expecting something to go wrong, and you're aware of your own heartbeat, that is called palpitations. So palpitations basically clinically means awareness of one's heartbeat, which is unexpected and inappropriate. It does not always mean there is fast heart rate. It could be slow heart rate. Right? So awareness of one's heartbeat is called palpitation, particularly if it's unexpected and it occurs at a time when when it's inappropriate. It's also called pounding of the heart, fluttering of the heart, but these are English words. In Pakistan, I think commonly it is described as ghabrahat. Ghabrahat, or the missed beats or skip beats or something just going on there, and patients find it difficult to put it in words. So palpitations are described by various words, but commonest I think is probably the ghabrahat, or I'm not feeling well, kuch ho raha, there's something going on there. Next. Physiological, because of the increased level of adrenaline and noradrenaline, and that's the situation I've just described. Anxiety state, depression, exertion, rage, excitement. Urdu poetry is full of descriptions of palpitations. Just pick up any poet, classical or modern poet, and you'll find palpitations running through the lines of poetry. Next. So that is physiological. Pathological, from the history, if somebody is having excessive use of tea, coffee, tobacco, these are the common ones in our culture. Alcohol, and particularly, is not in our culture, it's not common. And drugs, they can all be the source of palpitations. Some of the drugs, especially Buscopan, etc., they can cause palpitations in people who are not used to taking them. So what basically you should be looking for in history in a patient who presents with palpitation. First is, what is the mode of onset and termination? Shuru kaise hoti? That's a very important question asked from the patient. Shuru kaise hoti? If it is sudden in onset, starts like this and it goes on for a variable period of time, for minutes or for hours, and then stops suddenly, it is usually SVT or VT. Supraventricular tachycardia or ventricular tachycardia. That is usually sudden in onset and sudden in termination, does not involve sort of gradual phase in and phasing out. If it is slow in onset and termination, it is usually, but not always, sinus tachycardia. Sinus tachycardia is obviously a reaction to the situation, and that reaction develops over a period of time. You start becoming aware of bad situation, and therefore there's a gradual progression of heart rate from slow to palpitations. The duration. What is the duration of palpitation? If somebody says he's getting this thing, you have to ask how long does it last for. If it lasts for only seconds, then probably we are not talking about any sustained tachycardia, whether it is a ventricular tachycardia or supraventricular tachycardia. Sustained tachycardias will not last for seconds. They usually last for at least a good few minutes to hours. So seconds usually is the missed heartbeat, ventricular ectopy or atrial ectopic beats. When they are registered as inconvenient or missed beats, they are usually described as something that lasts for only seconds. So if somebody says it's got palpitations lasting for seconds, usually it means ventricular ectopy or atrial ectopy. Sustained activity over a period of minutes to hours usually reflects underlying supraventricular or ventricular tachycardia. What are the associated symptoms in these patients? Do you have any associated syncope? Do you feel dizzy during the time? If you're feeling dizzy during the time of palpitations, then obviously it is clinically very significant. Now it could be again supraventricular tachycardia or it could be ventricular tachycardia. And usually when you feel associated symptoms, one would also expect to have an underlying cardiac disease, structural cardiac abnormality. A normal heart, normal young heart, even if it is raced at 180 beats per minute or maybe faster than that, is able to go through with that activity for a prolonged period of time. Whereas a structurally abnormal heart, for example, ischemic heart disease, for example, hypertrophic obstructive cardiomyopathy, for example, mitral valve prolapse, for example, pericardial disease, endocardial disease, valvular disease, they are associated with associated symptoms such as dizziness. Patient may actually fall, may lose consciousness, may have to sit down. So associated symptoms with palpitations usually signify underlying structural cardiac abnormality. What are the precipitating factors? What are the situations that precipitate it? For example, after taking tea, coffee, after exertion, if something is happening during exertion, that is very abnormal. If somebody complains of palpitations during exertion, mild to moderate exertion, it is very abnormal and should be taken very seriously because it could be reflecting underlying ischemic heart disease. Somebody who's had myocardial infarction is going back to the mosque now, and during that he experiences palpitations that could be life-threatening ventricular tachycardia. So, especially if the precipitating factor is exertion, that is always worrying, and that usually signifies underlying ventricular tachycardias. One important question you should always ask the patient to do, and that's very, very easy if somebody understands it, to tap it out. Ask the patient to tap out the palpitations. For example, just ask the patient, "Kaise mehsoos kaise hota hai?" Can you just do it on the table? If it is fast and regular, you're talking about something which is regular and fast, such as sinus tachycardia or supraventricular tachycardia, such as AV nodal reentrant tachycardia or AV reentrant tachycardia, something which is regular. If it is fast and irregular, then we are talking about most probably atrial fibrillation. Right? Fast and irregular, atrial fibrillation. If you're going about thumping is forceful but slow, we are talking about anxiety-related palpitation, which is basically increased forceful contraction of the heart. It's not a rise in the heart rate. So that is basically most probably due to anxiety-related forceful contraction of the heart and thus causing palpitation. So ask the patient to tap it out. That can give you a clue as to the diagnosis of palpitation. Particularly, you can find out almost easily atrial fibrillation is irregular. Next. Right, what would you look for in examination of patients with palpitation? Commonest finding on examination is that there isn't any finding. It's normal physical examination in most of the patients with tachycardia. And commonest cause of palpitation in practice is a psychiatric problem. It's usually anxiety. The commonest cause of palpitation in general practice, not necessarily in cardiology practice, because cardiology practice is referred patients who have already been seen by the primary physician and they have been screened for anxiety and related disorder. But in general practice, the commonest cause of palpitations is anxiety state or depressive illness. So therefore, you're not going to find, most of the time, you're not going to find any positive physical findings in these patients. But, of course, you have to look for thyroid abnormality, thyroid dysfunction, easily missed. It is easily missed, especially in ladies, because ladies are almost covered from they're covered, their thyroids, their necks are covered, so you have to expose the neck to look for thyroid abnormalities in patients with palpitations. It's easily missed and it has to be diagnosed if you're looking for it. Cardiac enlargement, it can cause palpitations. Awareness of the heartbeat could be due to enlarged ventricle. If the ventricle is enlarged in cases of aortic regurgitation, as a sequelae of ischemic heart disease such as left ventricular aneurysm, these hearts are enlarged, their apex is next to the chest wall, and when it contracts, it usually gives rise to appreciable awareness of the heartbeat. So that's called palpitation. So any condition that results in enlargement of the myocardium, particularly the chamber enlargement, would be expected to be associated with palpitations. So you may find displaced apex beat because of aortic regurgitation. There may be diffuse apex beat because of left ventricular aneurysm, or there may be sustained apex beat because of the underlying hypertensive heart disease or hypertrophic obstructive cardiomyopathy. So these are some of the things. Epstein's anomaly maybe is a rare disorder. It's not usually diagnosed on clinical examination unless one is looking for it, but it's usually associated with palpitations and multiple clicks on physical examination. If found, one should suspect, but there's no way you can diagnose that apart from doing the echocardiogram. So it's an echocardiogram diagnosis, but there should be a suspicion of congenital abnormalities such as Epstein, mitral valve prolapse, and hypertrophic obstructive cardiomyopathy as the cardiac diagnoses that are associated with enlarged ventricle. Pulmonary hypertension, due to any cause, can give rise to palpitations. Again, it can be true palpitation or just awareness of the heartbeat. True palpitation means really tachycardia, and that is the patient appreciates atrial fibrillation, for example, due to pulmonary hypertension, or sometimes atrial flutter. Remember one thing, if the left-sided chambers are enlarged, you'd expect to have, anyone? Left-sided chamber enlargement, left atrial enlargement is associated with what kind of rhythm? Atrial fibrillation. Left side atrial fibrillation, and right-sided enlargement is usually associated with flutter, atrial flutter. So if there's a right atrial enlargement, such as in Epstein's anomaly, such as in patients who've got, due to other reasons, enlargement of the right atrium, they are expected to have atrial flutter more commonly than atrial fibrillation. Whereas the left atrial enlargement, such as due to common cause of left atrial enlargement in our society, mitral stenosis. So mitral stenosis is associated with atrial fibrillation. So atrial fibrillation is more commonly found in the left-sided chamber enlargement. Rhythm abnormalities, they can give rise to palpitation. So, such as SVT and VT, I've already said, we'll talk about that in detail when the diseases are discussed. But at present, you just remember that SVT is not a diagnosis in itself. It is just like saying that this hall has got 50 males, and a male is not a diagnosis. each person is an individual, has got a name, has got its own profile. Similarly, SVT is just a group of disorders which has got identifiable entities, and those entities, they've got specific diagnostic criteria and specific treatment for that. For example, SVT is sinus tachycardia, then you've got paroxysmal atrial tachycardia, then you've got atrial fibrillation, then you've got atrial flutter, then you've got atrioventricular nodal reentrant tachycardia, then you've got AV reentrant tachycardia, and then you've got bundle of His tachycardia. So each entity is different and it has got its own diagnostic and therapeutic modalities. So SVT is just a group of disorders. Similarly, VT is not a single diagnosis. VT is again a group of diagnoses. So monomorphic ventricular tachycardia, polymorphic ventricular tachycardia, sustained ventricular tachycardia, non-sustained ventricular tachycardia, Torsades de Pointes tachycardia. So again, you have to identify the particular entity so that we can direct our therapeutic management against that particular tachycardia. But rhythm abnormalities, whether they're SVT or VT, would be expected to be associated with palpitations. But there are tachycardias inverted commas, which are just slow tachycardias and therefore may not be associated with palpitation. It's just an exception to the rule, but by and large, all tachycardias are associated with palpitations. Rate abnormalities, sudden rise and fall in the rate, although it is sinus, but again it is associated with palpitation. So palpitations are due to rate abnormalities, rhythm abnormalities, cardiac chamber enlargement, and non-cardiac causes such as thyroid dysfunction or in patients with hypoglycemia. Again, it's a non-cardiac cause. The patient has got history of palpitations or feeling of awareness of the heart. Next, investigations. So what investigations would you ask? Again, as I said, the commonest cause is psychiatric illness or anxiety. So you're not going to be asking any particular investigations unless you found something on physical examination. ECG is the commonest investigation and should be done in all patients with palpitations. Because even if the patient is now sitting in front of you, does not have any symptoms or signs, patient may have underlying pre-excitation such as WPW syndrome. So patients may have underlying diagnosis on the ECG even when they are not having palpitations. So ECG is widely available, is cheap, and it should be carried out in all patients with palpitations. Echocardiogram is almost mandatory. It should be done on all patients with palpitation because there's no way you can diagnose HOCM, mitral prolapse, and some of the congenital heart disease such as Epstein's anomaly on physical examination. So first-time investigation of palpitations should include an echo examination of the patient. Holter monitoring is important and is probably underused investigation in our setup for two reasons. Firstly, it's not widely available. Most of the clinics do not have the Holter monitoring facilities, and those who have it, they do not have a dedicated cardiologist who will be looking at the results and its interpretation, and then it should be given to the patient. So very few centers are offering this service competently, which would be helpful for the patients. But Holter monitoring is basically just a small gadget. Nowadays, the size of that is becoming smaller and smaller. It is used, the disc is used nowadays, and therefore you can monitor the patient's cardiac beat for 24 hours or 48 hours or even longer, 72 hours. Now again, remember, the patient has to have palpitations during the course of the study. If during the course of the study patient does not experience palpitations, that examination may be within normal range. And whereas the patient does have underlying abnormality which is intermittent and it just did not show up during the time of the study. So therefore, you may need to repeat that on 2, 3, 4 occasions. And to get around that problem, which is so infrequent, some patients may experience palpitations only once in 6 months, or once in 2 months, or once in a month. So for that kind of situation, they've developed called loop recorders. Loop recorder is something that you just place under the skin. It's after a small local incision, just like pacemaker implantation. You just implant that loop recorder under the skin, and it is recording the patient's ECG over a period of months. And therefore, just like a pacemaker, you can interrogate that loop recorder and you can get the information, particularly in those patients who are troublesome and do not give an easy diagnosis. Telephonic monitoring or telemetry. Telemetry is another form of investigation that is usually used for patients with troublesome palpitations. It is just a small gadget which is applied to the patient. Patient's got it at home or on the person, carries it around. As soon as he gets tachycardia or palpitations, he plugs himself into the telephone, and telephone will transmit that ECG recording to a cardiac center, and you'll get a strip of ECG at the other end. And the physician will be able to see it either on the computer or an ECG strip on the paper, and he can make a diagnosis from that. So it's called telemetry or telephonic monitoring. Again, very expensive, and you have to have a system where you can trust the patients that they will not break it, and then it's very expensive. ETT. So here in Pakistan, we have only Holter monitoring available. The loop recorders are not available because very expensive again, because you have to put it inside, just like pacemakers. So very expensive. Not many patients can afford that. And secondly, you have to keep it in for at least a good few months. More of an investigational tool rather than clinical tool at present. But telephonic monitoring or telemetry is widely available in Western countries. It is very useful, and it helps in making the diagnosis very fast. ETT may be sometimes asked in patients with palpitations, because some of the palpitations may only become manifest on exercise. So therefore, you have to put the patient on exercise treadmill if all the other investigations do not give you any diagnosis. And as I said earlier, any palpitation which becomes worse or comes to the surface during exercise is very worrying. Usually it is ventricular tachycardia. I remember I was sent a patient who just came in with history of palpitations. I put him on the treadmill, and during the first stage, he produced sustained ventricular tachycardia. Sustained ventricular tachycardia that needed IV lignocaine injection in the clinic, was sent to the hospital, had emergency angiogram next day, and was found to have severe triple-vascular disease and underwent bypass surgery. So sometimes you need ETT to bring the palpitations to the surface to make a diagnosis. Next, non-cardiac causes. Thyrotoxicosis, I've said, is easily missed, especially in the ladies, because they're all covered, and therefore you have to ask them to uncover the neck to see the thyroid gland. Hypoglycemia can cause or can give rise to palpitation, but again, it's unlikely that the patient will present with palpitation. Usually they present with loss of consciousness or dizziness or something associated with abnormal sensorium rather than palpitations. Pheochromocytoma, it is very rare, and I think it's only found in the books. I've seen only one patient of pheochromocytoma in my clinical life, and that was in London. Usually the patients are very emaciated, very weak, very thin because of the chronic adrenaline and noradrenaline. They are catabolic, and therefore because of increased catabolism, the patient is extremely weak and emaciated. And there's a gallop, constant gallop, as if somebody is just whipping the heart, and the heart is just going at a rate of more than 120, 130, 140. So it's a chronic adrenaline and noradrenaline overload in these patients that lead to cardiomyopathy, palpitations, and sometimes hypotension. If it is adrenaline increase, it leads to hypotension. And if it's noradrenaline, then it is hypertension. So pheochromocytoma is not necessarily associated with hypertension. It may be associated with hypotension, depending upon what hormone is being released into the circulation. Fever, again, nobody presents with palpitation because of fever, but palpitations or increased tachycardia will be found in patients with fever. Drugs, particularly Buscopan, epinephrine, norepinephrine, they are associated with tachycardia. Bronchodilators can cause, yes. Next. Therapy. So the important aspect of palpitations is to make a diagnosis of that on positive grounds. And as I said, in common practice, I think it's going to be mostly anxiety-related disorder. So anxiety-related disorders or depression is going to be the commonest cause, and that should be addressed adequately. Any underlying cause such as structural cardiac abnormality, aortic regurgitation, mitral stenosis, and all the rest of it, they will be diagnosed and dealt with accordingly. But commonly is reassurance, especially in patients with tachycardia. And in those patients, you may choose to give beta blockers. Now, is there a caveat to use the beta blocker? Where would you not use the beta blockers in patients with palpitations? Apart from bronchial asthma. Right, okay, acute cardiac failure. But palpitations is probably not a part of acute cardiac failure. Usually it's shortness of breath, swelling, less. What I want to say is that don't think that beta blocker is the treatment for every palpitations, because commonly the beta blockers is just dished out to the patient. That's not the case. There is an entity in which the missed heartbeats or ectopy, ventricular ectopy, is a phenomena because of the bradycardia. If the patient is excessively slowed up, or his patient is bradycardic, then you get ectopic beats to fill in the gaps, as those ectopic beats are being registered as palpitations. So if you're going to treat those palpitations with beta blockers, you're going to make it worse, because the palpitations in these patients is basically a compensation for the bradycardia in the first place. And if you cause excessive bradycardia, you will probably make the situation worse. So any patient who presents with bradyarrhythmia interspersed with ventricular ectopy or atrial ectopy should not be given beta blockers, because that will make it worse. It's an escape phenomena in these patients. It's only the tachyarrhythmias, when the patient's got tachycardia and patient is complaining of palpitation, and you think the patient's got either anxiety-related disorder or patient may have thyrotoxicosis, as a perfect candidate for beta blocker therapy. It's your own choice. I think commonly used ones are atenolol, metoprolol, bisoprolol. Any one of these three will be used. As long as you use them in adequate dose, because under treatment here will probably not be helpful, especially if the patient has got thyrotoxic problem. You have to give a good dose of beta blocker in these patients. Pardon? If it brings down the blood pressure down?
If it is not desired, if it is also not...
Well, I mean, in that case, you have to titrate the dose, but I think most of the time, 50 milligram of atenolol or 100 milligram of atenolol are usually well tolerated in these patients. Again, this is only for those patients who present with sinus tachycardia of anxiety, due to anxiety or thyrotoxicosis. Whereas patients with SVT, supraventricular tachycardia of either variety, let's say atrial fibrillation, they're not going to be treated with beta blockers. You have to find underlying cause, and that is...
What will be the dose to begin with?
Pardon?
What will be the dose to begin with?
For the beta blockers, depends upon the size. If it's a small woman, maybe you can start with 25 milligram. If it's a big person, you can start with 50 or 100 milligram. But 100 milligram is not a big dose for a person of, a normal person. A male, 70 kg or 80 kg male, 50 to 100 milligram is a standard dose of atenolol. Metoprolol is again underutilized, it's underdosed, Metoprolol should be used as 50 milligrams 3 times a day starting off, and go up to 100 milligrams 3 times a day. Yes, 3 times a day. G? Metoprolol is only used for patients who've got specific indication for that, and that again depends upon patients who've got ventricular tachycardia. That would be used in those patients, for example, due to underlying ischemic heart disease, or patients who've got supraventricular tachycardia, which is not being controlled by commonly used drugs such as beta blockers. So in those patients like atrial fibrillation, you may have to resort to cordron use along with digoxin or beta blocker if they're not being controlled. But nowadays there's less and less tendency to use cordron on a long-term basis because of its toxic effects, because of its undesirable effects, not only the toxic, undesirable side effects in our situation, because it basically gives you a photosensitive rash. And here we are, most of us, we are exposed to fair amount of sunlight, and therefore it gives you a very bad photosensitive rash on the exposed areas. Corneal deposits, pneumonitis, hepatitis, ataxia, peripheral neuropathy is full of toxic effects, especially on a long-term basis, and especially if the patient is not going to present to you on a regular basis for follow-up. If the patient is living in a far-flung area, he keeps taking his dose, he may present with toxic effects. So therefore, cordron should only be used in the hospital settings where the patients can be followed up reliably and should have a very firm indication such as ventricular tachycardia or troublesome supraventricular tachycardia, atrial fibrillation in particular. It is not nowadays used for AV nodal reentrant tachycardia. It may be used for AV reentrant tachycardia, such as Wolff-Parkinson-White syndrome or others in specific situations. Right. Any questions for palpitations?
Third degree heart block.
Pardon?
Third degree heart block. Would it be contraindicated because
Obviously, that's self-explanatory, but third-degree heart block would not be associated with palpitations. That will be associated with Stokes-Adams, a dizziness, syncope, which is the topic of our next discussion. Next. Cause of palpitation in practice, in general practice, is anxiety-related disorders and depression. So in those patients, I think it will be very appropriate to find out exactly what's the cause of underlying anxiety, and if appropriate, you can use a judicious use of or the doses of tranquilizers and antidepressants. But remember, some of the antidepressants are also associated with palpitations, like tricyclic antidepressants. Syncope. What do we understand by syncope?
loss of consciousness?
Exactly. It's a transient loss or impairment of sensorium or consciousness. It doesn't have to be loss of consciousness. Remember this, and I think it's very important. The thing which I've written here is written in the books, and by and large that is true. But it does not always mean loss of consciousness. In fact, the commonest cause of syncope is associated with no loss of consciousness. And if you just ask the patient, were you aware of the people talking around you? And he would say yes. He or she would say yes. Usually it's a she. She would say yes. Because the commonest cause of syncope is vasovagal. And vasovagal syncope is associated with sort of as if the energy is drained off you. People will definitely tell you, jism se jaan nikal gayi, jism mitti ho gaya. And they just deposit themselves on the ground safely. This is another important aspect of vasovagal syncope, that they deposit themselves on the ground safely without hurting themselves. Anybody who will hurt himself or herself would not have a vasovagal syncope. And during that vasovagal syncope, although they look deathly pale, as if there's pallid, extreme pallid, they look like white sheet. And eyewitness account will be that the person was just basically lost, or she lost color in the face, but they would never lose sensorium completely to the point that they were unaware of themselves. They would always tell you there were people talking about around me, and I just came around as soon as I went down on the floor. So loss of consciousness has to be in brackets. It may not be a complete loss of consciousness, especially in vasovagal syncope, which is the commonest form of syncope. So usually it is an upright posture or sitting posture. So you don't get syncope when you're lying down, right? Syncope is basically a phenomenon that's observed either sitting down or more commonly in the upright posture. Vasovagal syncope is the commonest. Postural syncope again is in the elderly people with polypharmacy, usually with people who've got beta blockers, people who've got ACE inhibitors, people who've got some other antihypertensive or some other medication associated with loss in blood pressure result in syncope. So that's postural syncope. And then carotid sinus hypersensitivity, which is basically hypersensitive carotid sinus, which is found at the bifurcation of the carotid artery. At the bifurcation of the carotid artery, just below the angle of jaw, you have carotid sinus, and that is stimulated, and that results in inappropriate excessive stimulation leads to fall in blood pressure, and that leads to carotid sinus hypersensitivity associated with syncope. Situational syncope is due to cough, micturition, constipation. So elderly people again who are basically trying to do a strenuous effort to get rid of the excreta. Vasovagal syncope, as I said, is the commonest. It occurs in females more commonly than males. And what is the underlying pathophysiology? Anybody? The underlying pathophysiology is excessive sympathetic stimulation. Excessive, not less. Excessive sympathetic stimulation. If you have a combination of two things, that is be diagnostic of vasovagal syncope. What are those two physical signs? Volunteers? To diagnose vasovagal syncope, two classical physical signs.
Illness.
Vagal. What does the vagus nerve do to your heart rate? So bradycardia. Normally when you lose blood pressure, there should be reflex tachycardia, but here it is inappropriate bradycardia. So that is the inappropriate thing here. That normally you have a hypotensive situation which should be expected to be associated with sinus tachycardia. And here you have a bradycardia, inappropriate. You are supposed to have tachycardia. So one thing is inappropriate bradycardia in a situation in a person who is looking very pale. And secondly, as I said, hypotension, unrecordable blood pressure, or no pulse, or the person becoming feeble and weak. So feeble and weak pulse associated with bradycardia is diagnostic of vasovagal. Right? Especially if patient is looking pale. Patient is looking pale. Patient cannot feign paleness. They may go down and may try to sort of, pretend, but they cannot bring about the color change. So the color change associated with feeble and weak pulse with bradycardia is almost diagnostic of vasovagal syncope, and that's the commonest form of syncope. This is a form of syncope that happens in crowded places, in hot and humid places, after prolonged standing. Somebody is standing in the queue for hours and hours to get a half kilo of sugar, and he may have a vasovagal. So vasovagal is found after prolonged standing in hot, humid, crowded places, and that is due to excessive stimulation of the sympathetic nervous system. And that stimulation of the sympathetic nervous system results in the stimulation of a special reflex in the brainstem called Bizol-Jarisch reflex, which results in opposite stimulation of the vagus nerve. And that results in vasodilatation. Vagus is associated with vasodilatation and bradycardia. So therefore, patient tends to have both hypotension and bradycardia. The treatment of that would be to avoid those situations. Again, this is the commonest form in young ladies who are scared or who cannot see the blood. Any frightening situation will be associated with vasovagal. And these patients almost always never hurt themselves. So there's another characteristic. They never hurt themselves because they usually go down they slide down. They never go down like a thud. They slide down. So again, almost never hurt themselves. So these are the classical features of vasovagal. Bradyarrhythmia, bradycardia with pallor, hypotension or feeble, weak pulse with no history of injury, although patient may have a recurrent falls, recurrent syncopal attacks, but there's no history of any physical trauma to the body of the patient.
Not always. Sometimes it's
very occasional. I mean, it has to be, but by and large, classically, they usually, because there's a gradual draining of the blood pressure or fall in the blood pressure in these patients. They have a time to lean on to something. Postural syncope. Postural syncope is again because of prolonged standing, as it says. It's not due to activation of the vagus nerve. It's just because there's peripheral pooling of the blood in the venous system. You know that 3/4 of our blood, 3/4 of our blood is found in venous capacitance vessels. It's in the venous side of the venous vascular bed. Only 1/4 of the blood volume is found in the arterial circulation. So if the venous capacitance vessels are vasodilated, then obviously they are going to trap more blood, resulting in fall in the blood volume, venous return, and resulting in syncope. So that is postural syncope, and usually happens in elderly people, not in young. This is usually found in the young people, young or middle age. It's elderly people and who are taking multiple drugs, particularly beta blockers, calcium channel blockers, ACE inhibitors, and the drugs that can cause fall in blood pressure. Carotid sinus hypersensitivity is rare, and I think that's diagnosis that a cardiology, probably a unit or department, will make. And this is to demonstrate your carotid sinus is hypersensitive, and you do that by means of different tests. And one of that tests is called tilt test. Have you heard of tilt test? Tilt. Just for the sake of remembering the test, although you're not going to order it, you're not going to do it, but just if somebody does it, and you should know what was done. The tilt test basically, it looks at your sensitivity of the carotid sinus. Now, you lose your blood pressure because of two reasons: cardio-inhibitory or vasodepressor. Either you vasodilate and you lose your blood volume in the capacitance vessel, or cardio-inhibitory, in which the heart rate goes down, such as in vasovagal, is cardio-inhibitory, or combination of both. Now, in some patients, it is difficult to find out whether it is just vasovagal or whether it is postural. Patients that just have syncope and recurrent troublesome syncope. I have one patient who is very active, and now and again he hurts himself. He falls down, and he's fallen down in toilets, he's fallen down in the roads, he's fallen down in the home, he's fallen down and hurt himself at a workplace. Perfectly normal, 50-year-old man. And I've done almost all the investigations, and he has no abnormality on the ECGs, on the Holters, on the exercise stress test, on the echocardiograms. Everything is just fantastic. It's normal. When we did the tilt test, he was strongly positive for that. So what is the tilt test? Tilt test is that you ask the patient to lie on the table, on the nephrogram table, an X-ray table, and that table is tilted at 70 degrees or 60 degrees. Anywhere between 60 and 70 degrees tilt. So you are strapped up to the table, strapped up, so you're strapped up at the waist, and you've got your feet resting on the footrest. And then the table is tilted at 60 or 70 degrees, right? To the horizontal. So you are basically just tilted at 70 or 60 degrees for 3/4 of an hour, for up to 45 minutes. You stop the test after 45 minutes. And during that, you're connected to the monitor to have your blood pressure taken and to have your tracing of the heart. So you see the heart rate and you look at the blood pressure periodically. A positive test is indicated by fall in the blood pressure associated with either bradycardia or asystole, because your reflexes are now not supporting your blood pressure. So inappropriate activation of the reflexes led to vasodilatation and cardioinhibitory, both cardioinhibitory and vasodepressor, leading to asystole, total stopping of the heart. So you thump the heart, bring it back to normal, and put the patient, and you insert the permanent pacemaker in these patients, especially a special kind of pacemaker called DDI pacemaker. So pill test is basically to demonstrate the hypersensitivity of the carotid sinus. It is done in those patients who've got troublesome syncope to demonstrate the cardioinhibitory and cardiovasodipressor inappropriate vasodepressor reflexes. So this is one test that would be done as a last resort in these patients. Next. There's syncope called glossopharyngeal neuralgia. It's ninth nerve that is associated with pain in the oropharynx, and it leads to a systole. It's in the books. I've never seen one. So I don't think you are going to see one. Probably it's just once in a while that ENT surgeon probably will be looking at. So we might as well forget it. It's just to make the list. This is the common cardiac disorders. And out of the cardiac disorders, the things that lead to syncope is the Stokes-Adams attack. And the Stokes-Adams attack is associated with bradyarrhythmias. So it is a bradyarrhythmia in the form of second-degree heart block. What kind of second-degree heart block? Wenkebach? What do you think? Wenkebaching would cause syncope? Wenkebaching is a second-degree heart block, but it's out of the second-degree heart block, there are two forms, Mobitz 1 and Mobitz 2. Mobitz 1 is Wenkebaching, prolonged, progressive lengthening of the PR interval, resulting in misbeat. So that is not associated with syncope, and that is not an indication for pacemaker implantation. So second-degree Mobitz 1 is not an indication. It is not an indication for pacemaker. Second degree Mobitz 2 is an indication. That is 2-to-1 block or a fixed block or complete heart block. So it's a Mobitz 2 and complete heart block are indications for pacemaker implantation that lead to syncopal attacks in these patients. This is a form which is found in elderly people, but nowadays they're also found in middle-aged people. I've got a patient who's a 50-year-old man. He is an executive and he is getting this kind of problem at age 50. Usually it is a degenerative process, usually found in patients who are 70s and 80s. But this gentleman has got it in his 50s. Tachyarrhythmias can be associated with syncopal attack if the tachyarrhythmia is too fast or if it is found on underlying disease such as structural cardiac abnormality, ischemic heart disease. So Wolff-Parkinson-White syndrome on its own, or especially if it is associated with atrial fibrillation. Atrial fibrillation in WPW is almost, is a recipe for disaster. If you look at the abnormality in WPW is that it bypasses the AV node. So there's no delay in the AV node. The AV nodal delay, which is a common thing, is not there. The rules don't apply to that bypass tract. So therefore, the patient is basically having a re-entrant mechanism which is causing tachycardia. Now imagine if you are having atrial fibrillation at a rate of 300 or more than 300 or 400, and if that sets up a loop, re-entrant tachycardia, so your ventricle cannot respond at a rate of 300, 400. And therefore, these patients, they either degenerate to ventricular fibrillation, die sudden death, or they have very serious cardiovascular collapse. So WPW, not on its own, but when it is associated with atrial fibrillation, is very troublesome and can be fatal. So tachyarrhythmias, WPW, particularly with atrial fibrillation, or torsade de pointes. Torsade is again a ventricular tachycardia. It is a polymorphic ventricular tachycardia, not monomorphic, polymorphic ventricular tachycardia, which has got different axes in the same tracing. Normally, you've got the same axis, it looks the same, monomorphic, as the name says. But in polymorphic, it is more than one morphology of the QRS complexes. So it is polymorphic form of ventricular tachycardia, which is associated with syncope. So you lose consciousness. So whenever you have a patient with ischemic heart disease or metabolic abnormalities such as hypokalemia, hypomagnesemia, you've got some other abnormalities in patients with ischemic heart disease that can lead to loss of consciousness. Think of Torsades de Pointes. Then you've got Brady-Tachy syndrome. Sick sinus syndrome is also called Brady-Tachy syndrome. So you lose control on your impulse formation in the sinus node. Sometimes it's discharging at a very fast rate, so you get tachycardia or atrial fibrillation. And at times it goes excessively slow, and you have a sinus bradycardia, or you may have very slow or junctional. So you may have tachy-brady alternating, or maybe just at any time during the course of the day, you may have these abnormalities. Tachy-brady syndrome leading to syncope. What other abnormalities? Aortic stenosis, severe aortic stenosis and severe mitral stenosis. So stenotic lesions, because they are restricting the forward flow. So by restricting the forward flow, you basically compromise on the cardiac output. So decreased cardiac output would be associated with syncope. So severe aortic stenosis patients, they can present with syncope or sudden death, especially on exertion. Similarly, with very severe mitral stenosis, you may have patients presenting with this. I've got one 14-year-old milkman. He's a young boy, 14, and he's getting syncopal attacks at age 14, and nobody knew about his aortic valve. When we looked at, did the echo, we found his aortic valve is almost pinhole. It's less than 0.5 centimeters squared. The area of aortic valve is less than 0.5 centimeters squared. So in a young heart, 14, severe aortic stenosis can precipitate syncopal attack. And imagine if that happens to somebody who's 45 or 50 with structural abnormalities such as underlying ischemic heart disease, you are going to have patients presenting a lot earlier with syncopal attacks. So severe aortic stenosis is one form that can result in syncope, just like severe mitral stenosis. So any severe stenotic lesion would cause fall in cardiac output and syncope. Pulmonary embolism. Some patients, especially with massive pulmonary embolism, will present with syncopal attack. Now, I must say this is something which is, you probably you think this makes logical sense, it makes some sense, but it is not the presentation in these patients. Hardly any patients with pulmonary embolism is going to present with syncopal or recurrent syncope attack. They are going to present probably with chest pain, shortness of breath, and fatal complications rather than syncope. But just because it may be occasionally so, the commonest cause of syncope is, again, vasovagal, as I said,